All right, so we should be live here. Everybody come on in. We're just getting our cameras situated. Apologies for the late start there, but you are now viewing our Answers from the Experts live. So good morning or good afternoon, wherever you're joining us from. And a heartfelt thank you to our corporate partners for making this program possible. Today, joining us, we have Dr. Wei Ai. Dr. Ai is an oncologist and lymphoma specialist at the University of California, San Francisco. And we also have Dr. Debjani Sahni, who is an assistant professor of dermatology at Boston University Medical Center. So thank you to you both for being here with us today.
Thank you for having us.
Thank you. So the way this is going to work, if you haven't joined us for one of these before, it's a very informal, open Q&A setting. At the bottom of your screen, you'll see a little icon that says Q&A. And during the program, at any time, if you have a question, you can just go ahead and type your question in right there or through the chat. That would work too. And I will ask it aloud to our medical experts, and they will answer as best they can. So let's go ahead and get started. The first question we have is, let's see, it's a little bit of a long backstory, so I'll go ahead and read that and you can let me know, doctors, if there's anything I can repeat. My CTCL is under control with methotrexate. I have never had any chemo or radiation treatments. I have only had 2 serious episodes of CTCL, but for the most part, it is rather mild. My question is, would CTCL cause extreme, sometimes debilitating fatigue? I first started experiencing fatigue with the first signs of CTCL, although my diagnosis was years later. Could that have been a coincidence? I have tried every avenue for the cause, sleep study, heart doctor, thyroid, etc., to no avail, and no one seems to want to say that it could be the CTCL. And then she mentioned, I've moved to a new city. I will be seeing a new hematologist and oncologist and dermatologist soon, but would love to hear what you think. So I don't know if either of you have any input on that. Dr. Sahni?
Start with that. Hi, I'm Dr. Sahni. I've not actually heard of any of my patients complain of extreme tiredness just from the CTCL. And what you were telling me that it's controlled on methotrexate, my understanding is there's not much skin disease to see at the moment. Is that right? It's pretty controlled?
Correct.
Right. So, the causes of tiredness and lethargy, it's a lot. The most important things are to rule out things like thyroid, anemia, and all those things. It sounds like those have already been checked. You want to exclude all the, the serious causes or the reversible causes, as it were, of fatigue. But the cause of fatigue can go into as much as, incorporate things like depression, perimenopause. I don't know if I'm talking to a woman or a man. I might be talking to a man. But, there are many other causes of fatigue as well. And so I would hate to, could CTCL cause it? I guess conceivably it could. It would be very unusual. I wouldn't be able to explain why well-controlled CTCL should cause that. And so my thought would be to maybe see the primary care, go through all the tests that have been done and they've excluded, and then maybe look into broader areas of causes of, so stress, menopause, and things like that.
Okay.
I don't know, Dr. A, if you had any other suggestions for that.
Okay. Dr. I, did you have anything to add?
Yeah, so a lot of times the treatment of CTCL is the side effects that causes fatigue. So I don't know if your fatigue is worsened after you start the treatment of methotrexate. Methotrexate, I don't know what dosage you're on, even in the dosage below 20 milligrams. Even some people at 12.5, they can be feeling tired with that treatment weekly. So if that's the case, they usually see a pattern like you're more fatigued maybe a day or 2 after taking the pills, and then the rest of the week it's a little better. So if that is, if you see the pattern and you're convinced, you and your doctor convinced the methotrexate contributing to your fatigue or even caused your fatigue, that may be, if your disease is well controlled, it's maybe time to change to different treatment. That's another way of approaching it, to another thing you can investigate.
Okay, great. Thank you both. Let's see the next one. I've had mycosis fungoides for more than 30 years. In the past few years, it has progressed to the tumor stage. I've had several tumors surgically removed and then radiation on others. In the last year, it seems to have gotten particularly aggressive. I'm on Bexarotene, but it doesn't seem to be helping. Should I give it more time to work, or should I pursue a different treatment as the tumors still appear to be developing? And then he added, I just don't know if I should be seeing a slowing down in the growth of new tumors by now and the shrinking of older ones if the drug is working, or does it need more time? And so that's the first part of the question. So I'm going to stop there because it's kind of a long one.
Hillary, is this a live? Can we communicate with the patient or only via chat?
It's live, but we have to do it via chat, unfortunately. And
I see. So we can't really ask questions and get a response immediately.
So this was one that was submitted ahead of time.
Gotcha.
So if during the live, if there are live ones and someone can clarify things, then yes, we can go back and forth. But with this particular one, it was submitted ahead of time.
I see.
But let's see. I guess they did.
I can start with the first.
Okay. Yeah. Go ahead.
Tumors. So tumor. For mycosis fungoides, even people who have had a long history like yourself, 30 years, sometimes the disease can kind of take a turn, developing tumors. If the pace of tumor development and its response to the treatment, it really dictates what kind of treatment would it be for the next round of a tumor. If you have a single site of a disease, so like one tumor or maybe one or two tumors, lesions, radiation would be my first choice. And for some people, that will be it for tumor for a while. They'll go back to their patch and plaque stage disease and controlled relatively easily with a skin-directed therapy. But for some patients, their tumor develops faster than you can finish the radiation. Like you just finish radiation, then you have more tumors develop, or you finish radiation, you don't have tumor develop immediately, but relatively short interval of remission for tumor lesions. And those patients, in my mind, they need a systemic therapy. And if you try to stick Bexarotene, even though Bexarotene in the clinical trials showed evidence of activity throughout all stages, both early and advanced stages, but in my mind, if that hasn't worked for a little while, there is definitely other options. I think brentuximab is exquisitely sensitive for a patient with a tumor, exquisitely active in patient with the tumor lesions. Sometimes the tumor lesion responds like melting away in front of your eyes, but their plaques and patches may not responding that much, or they may come back a little earlier with the brentuximab, but that doesn't bother me. I think the purpose of giving brentuximab the systemic therapy is to control the tumor lesions, and then hopefully will put you back to the stage that you could just using skin-directed therapy for the patch or plaque disease. Bexarotene has, brentuximab has its own toxicities. If that's not available, or you could not tolerate it, another good agent, old chemo agent called Doxil, which is liposomal doxorubicin, is generally extremely well tolerated. There's some unusual but severe side effects, so you need to get treated with somebody who uses these all the time, and that is also very active in patients with particularly tumor lesions. And I think a newer agent, papulosis, also good for tumor lesions as well. But that's a like weekly treatment, and so far, mucositis is pretty common source. But so brentuximab and Doxil will be my first two systemic agents particular for tumor lesions.
Okay. Anything to add, Dr. Sahni?
No, I think Dr. A pretty much said what I said. What I would have said. It sounds like they've had the CTCL for a long time, and only more recently are the tumors becoming a problem, which, as Dr. A suggested, sounds that disease have moved on to become a little bit more progressive, a bit more aggressive, and this is where systemic therapy would definitely be helpful. And we would also go for brentuximab as the next first choice.
Okay, perfect. Thank you. And I apologize if I've been mispronouncing your name. Is it A or I?
I.
Okay. Sorry. I just want to make sure. Okay, the next question for LYP, is it better to apply clobetasol cream to lesions once a day or twice? Different doctors have advised different approaches.
I can take this one.
Okay, perfect.
So there's no great studies out there that say it has to be twice a day. I think they when you buy them on prescription, it typically says twice a day. But I remember there was one study that came out that showed once a day is just as good. For me, what's more important is patient compliance. You know, I know I'm not very good at putting creams on. If I had to do something twice a day, every day, I'm not sure how well I would do it. And so most of the time I tell my patients to do it once a day, every day, something like at night before you go to sleep. So it becomes part of your daily routine. And it's something that's happening consistently. So that it doesn't matter if you miss the odd day, but what you don't want to be doing is just getting fed up of doing this and missing many days in a row.
Perfect. Thank you. Anything to add, Dr. I?
Nope, I agree with that.
Perfect. All right, let's see. Is there a possible connection between MF and tattoos?
Not that I'm aware of.
All right, let's see. Have infrared saunas been able to help MF patients? Infrared saunas. Have you heard anything about that?
No,
No?
I'm not. I don't think I'm familiar with what an infrared sauna is.
Okay.
Yeah, me either.
Okay.
You go to a medical grade light treatment, I would say.
Yeah, with those type of things also, they're not regulated. You don't know what dose you're getting. Even if it works, it may work one day, not another, or in one place and not another place. So
yeah, I completely agree with that. Yeah.
Thank you. What do patients find most effective for incessant itching? Dr. Sahni, do you want to take that one?
Yeah, so CTCL notoriously is very itchy, but there are other causes of itch. So, you know, it's good to tackle all of it. Good skincare is number one, something that everyone should be doing. So what we typically say is no soap, gentle cleansers, and a moisturizer every day. That's number one, because if your skin is dry, scaly, whether you have CTCL or not, it's going to itch. People who have very itchy skin also end up scratching a lot, and you end up with what we call, excoriations, and that also makes your CTCL more itchy, because you kind of get this superficial infection being introduced into the skin, and that infection itself propels both the itch and the CTCL itself. So often when people are covered all over with CTCL, I'll give them some form of antibacterial regimen, whether that be a bleach bath, which sounds horrendous, but actually it's no more concentrated than swimming pool water. So it's very dilute bleach solution, or an antibacterial wash, Hibby cleanse. And it has the benefit of calming down the itch and also calming the CTCL down. And then we move on to oral preparations. What can you do from oral preparations? I'd like to hear Dr. A's views on this. We found gabapentin quite helpful in our patients, especially if you do it 3 times a day. And then if they're particularly itchy at night, maybe add in something like mirtazapine, so something that's a bit of a sedative and an anti-itch as well later on at night. We have done antihistamines, the allergy pills, but typically we find they're not as useful. So in our practice, we find gabapentin, mirtazapine particularly helpful. And of course, getting the CTCL under control, number one, because once that comes under control, the itch will come under control straight away.
Okay. Anything to add, Dr. I?
I agree with that. Yeah, I use the gabapentin quite a bit as well. I found it's, it's not based on the randomized control. This is an anecdotal experience. I found it's more effective in more people than Atarax, which is more conventional medications for itchy. But sometimes I increase the dose for the evening dose so people can sleep better. And like Dr. Sahni said, Emend, which has, it's an anti-nausea medication, has this so-called side effects. So it has another effect that's really, really probably the best anti-itch medication in my mind for the CTCL patients. But it's it's not readily available. But if you happen to be on some sort of systemic therapy, using that as antiemetics, as pre-medication, that will have the benefit of control itch for several days.
Okay, great, thank you.
And of course, hopefully, as you respond to the treatment, the itch will go away. You will, be more treating the root cause of it instead of just palliating the symptoms.
Definitely, thank you. I have MF stage 2B, and I have a hard lump that is formed on my leg, and I have other smaller lumps in my arms. Is it time that I have a whole body scan?
Yes.
Okay. Short answer, yes, definitely. All right, let's see. What is known about CTCL vaccine response in terms of spike antibodies and the effect on our T cells?
Vaccine is a COVID vaccine?
Yes, sorry.
Okay.
I don't know. I don't know if any studies it.
Yeah, I don't know anything reported for CTCL patients specifically. There have been reports for people with targeted therapy or general chemotherapy, and those patients would do not response. So I'll give you examples for people with CLL, which is systemic type of lymphoma. Patients with active disease, not on chemotherapy, their response rate is about 50%. Patient on therapy, but not rituximab, which is anti-CD20 antibody, their response is a little less than that, like 35 or something. But patient on rituximab, which is wiped out the B cells, which the cells amount, B cell antibody response. If the patient on rituximab within 1 year, there's no response to spike protein detected. That's for a different type of lymphoma, obviously. I don't think CTCL patients receive any CD20 directed therapy. So I would think that one is people who have a good disease control probably have a very good response. I would say no data for CTCL patients that I'm aware of, but you can have a sense of, the less so the treatment that's less wiping out your B cells, you tend to have a better response, and better disease control seems to correlate with better antibody responses.
Let's see. I was diagnosed with LYP 6 years ago. I initially presented with aggressive lesions on my legs. I was treated with methotrexate.
Methotrexate, yeah.
Thank you. For about 10 months. I have had a few various small lesions appear through the years, but nothing major. I was seeing my oncologist twice a year, and he would take blood work at each visit. I have had 2 PET scans in the past. My new oncologist did not take any blood work at my last visit, and I wanted to know how frequently you recommend having blood work done.
So I can start with this one. Can I just ask, so they are on the methotrexate right now?
I can ask them. Let's see. I can ask whoever submitted this question. Yeah. You could. No, they said no. They're not currently on it. Okay.
So and the disease is mostly under control by the sounds of it, off methotrexate.
It looks like it. Yes.
In that case, certainly in our practice, we wouldn't be doing regular blood tests if they're not on methotrexate. If their disease were to stay stable in the way they are, so occasional bumps which go away with a bit of steroid or something, the main thing is to check the skin and check for the lymph nodes, because there is a 20% risk of developing a second lymphoma in individuals who have LYP. So even if their LYP becomes more stable and less aggressive over time, you still want to keep an eye on those patients and examine their skin and examine their lymph nodes and do any tests if things change. So if everything's stable, I wouldn't have any indication.
All right. Anything to add?
Yeah, I agree. stable disease and no concerning physical exams. We don't scan anybody. We don't do any labs on a routine basis. Yeah. I mean, not at all, but.
Let's see. My sister has just been diagnosed with PTCL. Pathology report shows she is positive for CD2, 3, 4, 5, 8, and 7. She has a small rash on her wrist and a small lesion in her soft palate. She is otherwise completely asymptomatic. Having done some research in this area, I believe she may have CTCL MF, not PTCL. Any idea how we could find out?
You should go to an academic center that see these all the time and have a biopsy and have expert dermatopathologists review the scans. And clinical and pathological correlation is very important for this disease. So,
okay. Let's see. I have just been diagnosed with MF. Can treatments for osteoporosis have an effect on my MF? Tough questions.
Not that I'm aware of, Dr. I.
No, I don't think so. I mean, not I'm aware of either. So.
Okay. I am MF 2A 4 years ago, mostly clear, but what is the best way to treat the bottom? UVB is awesome 2 times a month, but bottom dark spots never go away. Doctor is thinking of doing a deeper treatment instead.
So it sounds like very limited disease. And so you want to keep to skin-directed treatments. So when you say dark spots, it's not clear to me, are those actual CTCL lesions, or are they what we call post-inflammatory pigmentation, where the active rash has gone away and it's just left a mark in the skin, which will fade over time? So without knowing what's left to treat, it's hard to tell.
Okay, thank you. Let's see. What other monoclonal antibody treatments are available for Sezary besides Moga? Dr. I, anything on this one?
Not approved. There's something in the antibody to curing that's in clinical trials and is expected to be approved for Sezary, but it's not approved yet, at least in the US.
Okay. What is MF papulosis stage? I have been recently diagnosed with this and I am still unsure what it is. My stage 1A MF has been doing well, but now the rest of my body has little bits of MF that look almost like pimples.
So I can answer this one. I think have they been biopsied and are they all part of the MF would be my first question, or is this a separate issue? So if they're biopsied and they're confirmed to be MF, then it depends, how many of these lesions, where are they, whether we give skin-directed treatment or move up to systemic therapy. If it's just a few lesions and so if those papules are papules of MF and there's just a few scattered ones, I'm not sure, I'm pretty sure that we could manage that with skin-directed therapies.
Okay.
Yeah, sounds reasonable. I do agree it's critical to figure out what they are before you figure out what's the best approach. And sometimes it's a MF and lymphomatoid papulosis coexist in the same patient, so that obviously will help. Knowing that will definitely help too. Yeah, I would agree with have the right diagnosis first.
Let's see. Is occasional use of melatonin to promote sleep harmful at all for those with MF?
I don't think so.
No, I've not heard of anything.
Let's see. What treatment and what specialist should I be seeing for early stage? For 3 years, I've been asking them to biopsy for lymphoma and they did not. Finally, I was tested for it and was diagnosed with early stage. So I guess they're just curious what type of specialist they should see with early stage.
So I agree with Dr. I when she earlier said, like, you want to have your diagnosis made at least at an academic center where they're used to seeing patients with CTCL and they're used to diagnosing that condition. And in an academic center, you would have access to a dermatologist who specializes in this, an oncologist, radiation oncologist. It will be part of the joint team. Once the treatment has been decided, often you can do joint care. So if you don't live close to an academic center, you could be managed by your local dermatologist. If it's early stage disease, a dermatologist should suffice usually. And as long as they're in contact with the academic center, so if anything changes or doesn't respond, they can send you back. That would seem reasonable. But if you have more advanced disease, so tumor stage and above, there should be an oncologist involved in the care.
Yeah, exactly. That's how it works in our multidisciplinary clinic as well. So.
Okay, great, thank you. If the rash in early stage doesn't bother me, do I have to treat it? Does treating it keep it from progressing further?
I can answer that. I have quite a few patients with 1A MF who've had it for years and years, and they don't treat it because it doesn't itch, it doesn't bother them. It's often on their buttocks and back of their thighs where they can't see it. And I've been following them for over 10 years and nothing has changed. And it's not because they're doing treatment or not. So the disease kind of has a mind of its own. If it's going to be quiet, it's going to be quiet, whether you treat it or not. Treatment obviously is very important if you're symptomatic from it, or if you can see the rash and you don't like the look of it. But is it absolutely essential to treat it if you have no lesions? I don't typically enforce that on my patients. Dr. I?
Yeah, I agree with that. I don't think I don't think that treatment, this is like a indolent chronic disease of cancer, if there's such an entity, but I don't think the treatment would change the natural history of the disease in each patient. So yeah, it has its mind of its own. I agree with that. Yeah.
I've had MF stage 1B for many years. My first skin plaque, which is over the size of a quarter, just showed up. Is this cause for concern or an indication of progression?
So there's just the one lesion that's bigger than the others, is that right?
It looks like they have been at 1B for a while, and then their first skin plaque ever has just showed up.
Okay. So my understanding is that maybe they were patches before they were flatter lesions, and maybe one has become a plaque. So I think on its own, I wouldn't be overly worried. I would just monitor and watch. It might just be that they develop a couple of plaques here and there, and they may be well maintained on the current treatment. And then it doesn't mean anything. It's more when I almost call it, if the velocity of the disease changes. So, something that's been sort of patches and plaques and plodding along in that way for years and years, and all of a sudden something new and rapid develops, is usually more a sign the disease may have changed. So I think as long as it's monitored closely, I don't think on its own it means anything.
Okay.
Yeah, I agree.
Let's see. This is a follow-up to the earlier question of the patient talking about UVB on their bottom. They said the dark spots used to be lesions. When I go to UVB treatments, it brings out more patches than they go away, but it leaves very dark lesions where I don't get the sun. And then they said excimer machine is what the doctor is mentioning to try instead of phototherapy for a deeper result. And so I think they're asking if you would advise that.
I think it sounds like the lesion itself has gone and it's left a mark. So what they're treating
Correct.
is more cosmetic rather than an actual cancer lesion. My specialty is not in cosmetics, so I don't want to pretend I know. But if the doctor feels confident, lasers have been used for areas where there's post-inflammatory pigmentation. If the doctor feels comfortable that confident that they can do a better result, I don't see any reason not to.
Okay, thank you. How common is it for LYP to switch from type A to type B? I initially had the more aggressive type, but I was told it changed to the less aggressive type. So is that common?
Maybe Dr. Saudi can answer that.
Yeah, so my understanding is the type A, B, C, D are more pathological types. So it's more important to a pathologist when they're looking down the microscope. as to is it type A, type B, and what it means to them is a certain pattern of the cells under the microscope. In reality, all the types pretty much behave in the same way, respond in the same way. And in fact, if you take 2 or 3 different biopsies from the same patient, you might find that 2 or the 3 of the biopsies have 3 different types. It may come back as A, C, and D, for example. So the type in itself doesn't make a difference. I don't label my patients with LYP type A or C or whatever. Okay. It's more of a academic thing, you know, and how it looks, but it doesn't alter the treatment.
Let's see. Do you have a recommended way to get rid of redness? And they have in parentheses MF. So I don't know if there's nothing else there. I don't know if that's a pretty general question. And this one was unfortunately submitted ahead of time.
More like a treating MF.
That's what I was going to say, treat the MF. Yeah. I don't know of any other.
Okay.
Yeah.
Let's see. Are tests available to identify patients who have made antibodies to the COVID vaccine? Are there any trials at this time?
I can take that. Yes. So in the US.
Yes, I'm sorry. Yes.
Okay, so in US, the Lymphoma Leukemia Society has launched a big trial, like a populational study, and to evaluate, efficacy of the vaccine in cancer patients and definitely in the lymphoma patients. And their website, you can just register lls.org, I think. Or .com, I don't remember, but if you Google Leukemia Lymphoma Society, you find it, and you register there, and they'll send you to LabCorp to have a particular antibody test. It's the antibody against the spike protein. It's not the antibody against a nuclear capsule. That's a different test. So they'll give you a actually quantitative titer of the response if you have it. But a few things that I want to highlight is one is we don't know how much, what titer was the cutoff of the titer that will correlate with protection. So, and two, even for people who don't have B cell mediated response, they may have T cell mediated response, which we cannot measure at the current time. I think just those 2 points that I want to highlight because people get very anxious about these numbers. Yeah,
definitely. Thank you. What are the most effective treatments for patients whose biopsy showed FMF in the scalp and face and MF in other areas of the body? Is there a topical that is safe to use on FMF skin around the eyebrows without making my skin look bad? Dr. Sahni, anything on this one?
So follicular-tropic MF is typically, it goes deeper into the skin and can be more resistant to certain treatments. So typically those patients, I use more than just topical therapy because the topical alone usually won't do enough. So creams and lotions won't be enough. Radiation works really well. I've used it on the head, and I'm not personally, I've sent my patients for radiation, and it's worked very nicely on the head and neck area. Bexarotene pills have worked nicely. So I would slightly up the treatments if there's follicular-tropic MF involved. Whereas on the rest of the body, maybe something like topical steroids or phototherapy alone may be enough.
Anything to add, Dr. I?
No, I agree. I think when we do for people who are good candidates for phototherapy, we tend to give them PUVA instead of a narrow band if with a follicular-tropic. I don't know if Dr. Sahni, are you guys doing that sometimes too?
Yeah, we don't always have good access to PUVA here. We used to, but we don't anymore. What I've been doing is if I do end up doing narrowband UVB, I will add in Bexarotene with it. So
that's a good idea. Yeah, good idea.
I had total skin electron beam in 2009. Is it still very important for me to avoid sunlight?
2009, that's a long time ago.
Yeah.
It's always
No.
important to avoid sunlight.
No more than usual. I think what
Exactly.
yeah, avoid sunlight as we recommend to everybody, but I think what
Yeah.
they say at the beginning, because you get radiation dermatitis, and if you are in the sun, that can cause more pigmentation and darkening of the skin. So
Okay,
you want to avoid that. But from 2009, you should be over that.
great. But still wear sunscreen, I'm sure.
Yes.
Yes.
Don't black and burn, please, or overly tan.
Yes, let's see. Okay, do people diagnosed as children have less chance of advanced disease when they are adults? I don't know if you can even answer that one. Is there any way of knowing?
I have to say, I'd like to hear Dr. I's view on this also, but usually children tend to get the more indolent forms of MF, such as hypopigmented MF, for example. And so even when they're an adult, something like hypopigmented MF still behaves in a very indolent way. LYP is also something that children could get. I'm not sure that it changes unless the disease itself was going to change. That would be my thought.
Dr. I, anything to add to that one?
Yeah, I completely agree with that. I think that children tend to be diagnosed with early stage, like a 1A disease, and studies have shown that they have the same life expectancy as the controls who don't have MF. So they tend to have a better outcome, but we don't know if because that most of them are early stage or because they just, they're being children. So, but I don't, 1A stage disease is always have a good outcome. So we can't say that nobody will ever progress, but I think general has pretty good, very good outcome.
Perfect, thank you. When I have a relapse with new skin patches, I get intense throbbing in my armpit along with the skin patches. How common are these symptoms? And then they added, I get relief for the skin patches on the short term with steroid cream. Is there anything I can do to get relief from the throbbing? It's very painful. Either of you have any advice for that one?
I'm not sure what the throbbing is caused by, and sometimes the lymph node of the draining lymph nodes of those lesional areas can be inflamed. That could cause maybe some discomfort. If that's so, then it should go away after you treated the patch lesion.
Yeah.
And if it doesn't go away, it's hard to know what the scenario is, whether the person has lymph nodes or, it's hard to know exactly what it is.
Okay. Let's see. Is Gemzar chemotherapy a recommended treatment for MF?
Gemzar is a kind of a chemotherapy. It's one of the many agents that are available to treat MF. So whether that's the right thing for particular patients, it's it's individualized. So.
Okay. Let's see. I was given my diagnosis about a month ago, stage 1A. I've had the rash intermittently for about 5 years. What are the chances of it getting worse? These are hard questions.
So it was 1A disease?
Yes,
1A, yeah.
Correct.
And so the chance of it getting worse?
Correct.
So as Dr. I mentioned, it's unlikely. 1A disease typically has an indolent course, and so in the vast majority of cases, we wouldn't expect it to progress. But every lymphoma is different. It could transform. There's always a possibility. I always tell my patients, if it starts behaving differently, they should come and see their doctor sooner. But in general, I would be positive about it.
Okay.
Yeah, I agree.
Let's see. I was diagnosed with stage 1A 18 years ago. After getting it more under control by the use of UVB light, I've always had one teeny little patch on my back that comes and goes depending on my stress level. A couple of years ago, another small patch appeared on the upper part of my thigh. Even with light treatment and putting cortisone cream on the affected spots, they never seem to fully go away. I just wonder why, when I originally did treatment, I was able to get rid of 90% of the other patches, but I have these 1 or 2 stubborn patches that don't want to go away. And bottom line question is this normal? And is there enough research to know what to expect for the rest of my life? And then they added, I'm 56 years old. So stubborn patches, is that normal?
Yes, it could be. So everyone's MF is different. Some people have patches and plaques, and they respond like all the patches and plaques disappear with treatment. We certainly have patients with a similar problem where there's a couple that are just stubborn and won't go away with the treatment easily. And it may be that they need a different type of treatment in those areas. So depending on the size and thickness and where the lesion is, one option. So if it's a small lesion, if it's a thin lesion, you could try topical imiquimod. So it's a different way of getting the body's immune system, using a cream, but getting the body's immune system to attack the lymphoma. And I found good success with that on some of my patients who have stubborn plaques and patches. If it's a more significant lesion, then a small dose of radiation can work very nicely and make it go away for good.
Anything to add, Dr. I?
No, completely agree.
Perfect. Is there any breakthrough into the cause of CTCL? Is this condition for my life? Why does my skin clear and then break out again with no change of diet or activity? So is there anything you can share as to the cause? I think is the general question.
No, unfortunately, we don't know what the etiology is for CTCL, why some people get it, some people don't. In terms of intermittent flares of patches or lesions come and go, and that is the natural history of this disease. That's expected rather than exception. So I usually tell patients, even let's say with 1A patients, and I will say, hey, this is generally a really good outcome, but it's going to stay with you for your life. It's going to come and go, and does not mean that's going to be, for the most part, this doesn't necessarily mean that's going to be life-threatening, unless of course I change the characters and develop, tumor lesions or ulceration, whatever. But generally, that is, I would say, the wax and waning of these lesions are really expected as part of the natural history of the disease.
Okay. Would you advise the use of Keytruda in treating my Sezary syndrome?
That's a harder question. Okay, so that's a question that can take a long time to discuss, but the bottom line is, I think pembro checkpoint inhibitors definitely have activities in Sezary syndrome. It's been demonstrated, published, and investigators from Stanford has published that in Journal of Clinical Oncology just recently. But there are patients who have hyperflares, have flares of the disease. And I think the most recent data show there's an isoform variance of PD1 that can predict who's going to be flare, who's going to respond. So the short answer is some people have good response lasting a long time. Some people have progression of the disease even shortly after starting the treatment. Currently, we're still finding and validating the biomarkers for hopefully we could tell patients what, you have this biomarker, so you're going to be the one who benefit from this treatment. So therefore we'll give it to you. And we can tell the other person, well, you don't have this marker, so you're going to be less likely to have a great response. We won't give it to you. So we don't have that tool yet, but it's been actively researched right now.
Okay, thank you. What can I do if I am not sure if prescribed ointments are having an effect in slowing down my disease? Should I leave them on selected parts of the skin and see what happens? I have some small skin tumors which have been stable for over a year with clobetasol. I've got a rash where it seems the ointment, I don't know how to pronounce this, I'm sorry.
Mogamulizumab? Wait, no.
Mogamulizumab furoate.
What? It's an ointment.
Mometasone furoate.
Furoate, yeah.
Okay. Doesn't stop the progression. The creams may have side effects, and I'm not sure if I should risk them if they show no or little effect.
Without seeing the lesions, and it's hard to say, but I wonder if if the creams, there are other treatments other than topical steroids, definitely, especially if you're getting tumor lesions, and that adding in phototherapy or radiation or going on oral Bexarotene. I mean, without assessing the whole patient, it's hard to say this is what you should be on. But listening to it, sounds like you could be on a better treatment or a combination of treatments that could give you better control than what you have. And topical steroids work in some, thinner lesions, limited lesions of CTCL. Does a great job at doing that. But, the type of lesions that you're describing, I think you should be on other treatments.
Okay. Is there any link between diet and flare-ups? I assume they mean with MF. Or is there any known connection between diet and disease?
Not I am aware of, not diet. I have heard anecdotal experience. Dr. Saudi, I would like to hear your opinion on this. Like stress can precipitate some small flares.
Yeah, I've heard that a lot. And I mean,
yeah.
Like stress
is bad for you.
Exactly. Stress can affect our immune system. And this is, a cancer of the immune system. So it makes sense why that might be. But then stress affects everybody in a different way. So it's not something that you can predict either. Right. We're not familiar with any diets.
Okay.
Yeah, I agree.
I have developed growths on the top of both fingernails and toenails. They are unsightly and annoying. What can or should I do about them? I'm so sorry, my dog was barking.
That's okay.
Apologies, everyone.
I think so. My question would be, what are the growths? Again, what are we talking about? Are we talking about lesions of MF? Are we talking about tumor lesions? Are we talking about non-MF lesions?
Okay.
Are we talking about the nails themselves? Are the nails very thick from MF, which can sometimes happen?
I think that this person has Sezary. What's that?
Guessing the nails are involved,
okay,
which they often are in Sezary. Usually it's involved getting the Sezary under control.
Okay.
And if that's under control, the skin comes under control, the nail will eventually grow out.
Okay. Perfect. Let's see. How can someone get their diagnosis revised or confirmed as being in remission from CTCL? Does it go into remission? Is there is there a way
Dr. Saudi, you want to take that first?
I'm not sure I would call anybody full. We don't know. Like, yes, people, definitely there are patients of mine who have had disease for a while, and then it almost like burns out and they hardly get any lesions. I've certainly had a handful of patients like that. Remission, I guess, is to me clinical. So if they've got no skin lesions, they've got no internal disease, I guess they're in remission. How long it will last, I don't think we can predict, and we would have to wait and see.
Yeah, I agree. I think a complete remission in CTCL is a very high bar because
okay,
not a single thread of the redness anywhere, and it's a clinical completely. I mean, if you biopsy the skin, if you do like a deep sequencing, I mean, you might find a few MF cells, but that's not clinically significant. It's not impact your management. So that I think clinical remissions definitely can. Most people get a partial remission. It's again, that's a common goal. It's a natural history of this disease. So.
Okay. This next one isn't quite a question, but I assume they're just seeking advice. I'm 80 years old. I've had CTCL for about 15 years. This year, it has spread all over my legs, arms, and chest. I've been treating with topical medications and in the sun a lot too. I'm getting concerned. So I guess, is there any general advice that you would offer this person?
So sorry, I missed that they have lots of lesions on their legs.
Yeah, he said it has spread all over his legs, arms, and chest this year. And he's treating with topical medications, but he's getting concerned.
Oh, I think when you're getting lesions all over your body, it's very hard to chase them with a cream at that point. So I think the place for creams is when you have few lesions that are overall thin and localized, and that's not what I'm hearing here. So this would be a time for the physicians to be involved and offer up some other treatments.
Definitely.
Yeah, I agree.
It's hard, a lot of these questions too, to not be able to see the patient, and so we appreciate the advice you're offering. It's difficult, I'm sure.
Yeah.
Let's see, does mycosis fungoides come and go?
Yes, it does.
Okay. I have stage 2 folliculotropic mycosis fungoides with large cell transformation. What would be your recommended treatment options? So stage 2B FMF. Is there a general treatment option for that?
I don't think there are many treatment options and approaches, but it really depends on the patient and their other comorbidities, and where the lesions are and how it's affecting them.
Okay.
I don't know, and it can be approached in a mixture of ways. So I don't want to confuse the patients by saying this is the one way, but it could involve systemic therapy plus or minus radiation therapy. I guess those would be the kind of thoughts.
I agree. I think one thing Dr. Saudi and I both want to highlight is that it's such a rare disease. You know, I always tell patients it's like 2,000 new cases in the States a year. And if you compare patients who have breast cancer, that's only affected half of the population, that's 250,000 per year. So because this is such a rare disease, it really truly requires experts to manage these disease. And like Dr. Saudi said, once you have a treatment plan, you can, collaborate with a local dermatologist and manage that. I think people really would benefit from seeing experts in the academic centers in a multidisciplinary setting.
Mm-hmm. And we so appreciate all the answers. Like I said, I know it can be very challenging to answer questions when you can't talk directly with someone or see them. So we're just really appreciative. Let's see, we have time. This will be our last question. I didn't even realize what time it was. I have a residual papule from my first lesion. Occasionally it hurts. My initial lesion was large and ulcerated. It really hasn't changed since it healed. I just wanted to know if you think it can turn into a full-blown lesion again. Ending on an easy one here. Sorry, guys.
Yes, it always could. That's a possibility. If it's very small, you could use something like radiation or surgery and just remove it if it's bothersome. That doesn't stop other lesions from popping up somewhere else on the body if it was going to. So it kind of depends on, what's left of this lesion, how bothersome it is, where on the body. You could use something local to get rid of it, but that doesn't necessarily cure you.
Anything to add, Dr. I?
No, I think I completely agree with that.
Perfect. Well, thank you both so much. We're so grateful for your time and your expertise, and just thank you for being here with us today and handling all of these tough questions. We really appreciate it.
You're very welcome.
Thank you
for having me.
And thank you for everybody joining us today. We hope that you found this to be helpful. We are grateful that you joined us today. And just to let everyone know, on Monday at 7 Eastern time, we will be discussing the USCLC workshop on CBCL recap. So if you'd like to join us for that, that will be on Monday. And otherwise, thank you. And we hope to see you at a program soon. So have a wonderful day, everybody. Thank you.
Thank you. Bye-bye.
Bye.